I've been on the coast now for about 12 months, thereabouts, and I'm from Brizzy, but otherwise I've been trained through Queensland and in Toowoomba, and then came down here with my family, my wife and 4 kids. So we're really happy where we're settled and enjoying work through John Flynn as well as Tweed, where I'm a VMO in both spots. A lot of my interests are in skin, head and neck, paediatrics, but we also see a lot of this trouble, largely due to the incidence, and and we do play a role in the patient's management. So I just want to run through some surgical aspects of the management, but just a broad overview as well. Now, we're all familiar with these patients, and just to cover sort of a definition, it's that OSA is that periodic, partial and or complete obstruction of the upper airways during sleep, and it's disrupting the normal ventilation and sleep patterns, causing lots of arousals, to restore the patency, and resulting in daytime tiredness, mood disturbance. But the major thing is those long-term sequelae that we're concerned of, that are well recognised and accepted. The incidence is probably higher than that. That's in adults and kids, roughly 3%, worse in males. We accept that at least 10% snorers, even in children, and the incidence in children is probably a lot higher than we actually realise too, and what we actually treat. Just some fairly dry definitions. Snoring being the partial obstruction or vibration of tissues, apnea being the cessation of ventilatory flow for greater than 10 seconds, and there's multiple types. Obstructive, which is the major one we're talking about, but we often do see the mixed in our sort of patient mix as well. Hypopnea being a decrease in airflow, respiratory effort-related arousals, which is a sequence of breaths over 10 seconds with increasing efforts that terminates in an arousal, but not so much an obstructive or pause in the breath. And then we get those sort of all together to give you an AHI, but the best one being the RDI overall, which is all of those apneas, hypopneas, and RERAs together to give you a real understanding of their respiratory disturbance index. Our AHIs, the Australian criteria being less than 15 normal, and you can see mild, moderate, and severe. Not unusual for us to see the severes up to 40 to 70 per hour. That's apneas. The criteria is different in kids. If you ever get a sleep study, which is uncommon, at the Children's Hospital, yes, you'll see them done, but not for the general patient mix. With less than 1 being normal, but just over 1 is still counted as mild, but greater than 10 being severe. I've already mentioned, why we're worried about this, but it has true increased incidence of mortality, cardiovascular disease, stroke, heart attack, arrhythmias, and also concerns with neurocognitive function. In particular in children, there's been studies that have demonstrated concerns with reduced IQ scores in children with moderate to severe sleep apnea, and that's still being elucidated. Obviously the increased risk of car accidents, but otherwise endocrine dysfunction, and also significant marital issues that we all know it's often the partner that's presenting and having these complaints. I won't bore you too much with the pathophysiology, but it's an important principle. The Bernoulli principle and the Venturi effect going hand in hand to cause increased airflow through the narrowing, which lowers the pressure, causing the collapse. And that is a significant factor, obviously, in the cause of sleep apnea, and also things like stridor that we see obviously as well. It's all a balance between the dilating and collapsing forces. So in particular, the pharyngeal muscle tone, maintaining the tone, and what we know is that a lot of these patients spend more time in REM sleep when they're more hypotonic, and therefore have more collapse. And otherwise, a significant factor being the weight of the extrinsic tissues. The large BMI is heavily associated with OSA. It's on a spectrum from primary snoring, upper airway resistance syndrome, and obstructive sleep apnea, mild, moderate, and severe. So we think about that spectrum and the impact on our patient. So we can see as we have normal resistance with no snoring, as upper airway resistance increases, we're developing symptoms, snoring, as well as daytime symptoms of tiredness, obstruction, hypoventilation, leading on up to obstructive sleep apnea. So the major risk factors that we have to consider and look for in our patients, the patients we come in and we think, could this be somebody with it? Obviously male gender. In children, ages 2 to 5 seem to be the higher age group, but also obviously into middle age for adults. Raised BMI in children and adults. History of smoking, respiratory disease, a lot of the inflammation in the nose, the pharynx, as well as the lungs, contributing to poor respiratory function, as well as the use of sedatives, so sleeping tablets, alcohol, heavy alcohol use, antidepressants. All of these things are factors that can reduce the, can increase the incidence of sleep apnea. Otherwise, particular ones being syndromic, craniofacial anomalies, they're obviously the ones associated with anatomical factors that and hypotonia, particularly trisomy 21. And these are the kids in particular that we're getting sleep studies on. You know, we see a lot of parents asking, should we get a sleep study? It's really reserved for the syndromic craniofacial kids. And obviously, risk factors being the anatomic thing, and that's when, you know, consideration of ENT input, even maxillofacial input, is important because there are anatomical risk factors that lead patients to having that predisposition. So nasal obstruction, large tonsils, large tongue base, large redundant palate, retrognathia of the mandible, as well as maxillary or mid-face hypoplasia, and that's those sort of Crouzon's Apert syndromes with their narrow mid-face and collapsing in the hypoplastic mandible, maxilla, sorry. We know and accept that a lot of these patients have multi-level obstruction, so the majority do have multi-level, so we're talking nasal, pharynx, both at a retropalatal and a retrolingual level. So you've got to think about the bottleneck along the system. So we could treat the nose, but there may still be palatal and retrolingual sites of obstruction. The patient still needs CPAP. So these sorts of concepts have to go through our mind of where this patient is obstructed. And the best results surgically come from multi-level surgery, not all at once, but often in a staged fashion. The other sort of pathophysiology being, I mentioned the low tone during REM sleep and the impact of sedating pharmaceuticals as well as alcohol on neuromuscular tone. Body habitus clearly in terms of soft tissue, weight distribution on the airway, and also sleep position, supine being worse, side sleeping better. The history, and so what we're sort of looking for is different between adults and kids. As I said, a lot of this comes from the partner, but you know what we're looking for is all of those symptoms and from the particular patient, the morning headaches, unrefreshed sleep, and also their occupation. What sort of, are they in a high-risk occupation of falling asleep, truck drivers, etc. And also the presence of any comorbidities or sequelae already. And also we want to know what their CPAP usage is like. You know, often they're coming along because they can't tolerate the CPAP, and we can look at their CPAP reports to look at their compliance, how often they're using it, how many hours per night they're getting use, as well as what sort of pressures are required for their CPAP to be effective. In children, the important symptoms being morning tiredness, snoring, gasping, choking, any signs of apnea, restlessness in the sleep. One of the big ones being bedwettings associated with severe sleep apnea as they're spending more time in REM sleep. And the other question that we always ask is choking on solids, choking due to large tonsils. And in the real severe cases, failure to thrive. These are the obvious questionnaires that are now required for us to get an MBS-funded sleep study, Stop, Bang and Epworth Sleepiness Scale. For us, we always get our patients to give us a worst-case scenario so that we can get them across the line often to get a sleep study. Now, I'm not going to go into the ins and outs of sleep studies. It's probably more of a respiratory question and topic. But for us, the difference between the home-based ones and the lab-based ones, The home-based ones are improving, but they're not the gold standard, clearly. They're sort of level 3, level 4. The level 1, level 2 sleep study being in the lab, by far and away the best test that we can get, but obviously accessibility, costs, the supervision of a respiratory scientist as well as input from respiratory physicians increases those costs and limits that access. So often it's starting out with a home-based study might be something that we get a patient to do. So this is often sort of gives us a bit of a sign of relief that we might be able to help this patient. So seeing these enormous grade 4 tonsils gives us a clear sign that this is something that we can help surgically. They used to call me Tonsil Tim at the Queensland Children's Hospital, and so every time I saw some of these, we'd always high five because you know that you could help these little kids. So this, I'm sure you're aware of the tonsil grading system. Just in case people aren't. Grade 0 being no tonsils. Grade 1 small, confined to the pillars. Grade 2 50% across to the midline. Grade 3 75% across to the midline, and grade 4 is the obvious kissing tonsil. What we're really looking for in kids, and our assessment is different. We don't use nasendoscopy. Usually between the ages of 2 and 8, we're unlikely to get a camera down the nose. Mm-hmm. Above less than 2, we can pin them with mum and dad's help. Greater than 8, they're usually compliant. So with kids, we have to make an inference based on their breathing, based on their mouth breathing status, the nasal congestion, the reported symptoms. We're talking adenoid facies, that sort of looking like they haven't slept or they've never breathed through their nose. They have a long mid-face, dry lips, baggy, dilated vessels under the eyes, almost like an allergic shiner kind of appearance. Obviously we're looking for syndromic features, which is often obvious, but we're looking at the mandible position. Is this a really retrognathic child? Just small jaw that needs more time to grow. The tonsil grading, the palate, mainly the palate, is the palate intact? Kids don't tend to have long, elongating, collapsing, obstructive palates. It's more about the presence of cleft palate, which actually limits our ability to take their adenoids out because of the risk of VPI. And otherwise, the presence of heavy nasal mucus, consistent with ERTs or allergy, and large turbinates. Velopharyngeal insufficiency. So food going up the nose, food and water going up the nose, effectively. So they can have a really breathy voice because they get all their air when they talk goes out their nose. It sounds a bit goosey. Yep. In adults, it's a totally different examination overall, obviously. We're looking at the BMI, also taking note of their neck girth, so big bulky thyroid goiter that may need to be addressed, big just general body habitus of and the impact on the neck, short neck, other neck masses. We've got to consider their anaesthetic risk factors for having a difficult airway. If this patient's going to need surgery, they're going to have a difficult airway. The position of their mandible again is often in conjunction with that. The tonsil size, if they've still got tonsils, sometimes it creeps up on us in the adults with grade 4 tonsils come through to the rooms. The position of the palate, so is it a more posteriorly based palate or more anteriorly sitting up nice and suspended with not too much elongation or not too much extra soft tissue. So you can see like minor salivary gland tissue often within the substance of the palate or the uvula, which is often has a role for lubricating the throat and lubricating the pharynx, but that's often redundant, excessive, and can be a large cause of snoring. The size of their tongue, the bulk of their tongue taking up a lot of the pharynx, and also their Mallampati score or Friedman's classification, which I think we talk about next. The position of the tongue and the palate and the relationship with that. That's also about their airway risk. With the nasendoscopy though that we do get with adults, we're looking for polyps, sinus inflammation that could be causing that. Often those sinus symptoms are akin to the features of sleep apnea, that tiredness, congestion. Patients can still feel like they've had unrefreshed sleep. And it may not be OSA, but it could be severe chronic sinusitis. We're looking for other masses or residual adenoid tissue, which is unlikely in an adult, but otherwise sites of palatal obstruction, the site of looking at the bulk of the tongue base, so the lingual tonsil tissue at the back of the tongue base, which is not removed with the tonsillectomy, can be big, inflamed, and bulking backwards, falling backwards. We do hypotonic manoeuvres where we have the camera in the nose and we squeeze their nose and get them to take a breath in through the nose. Now that generates like a reverse Valsalva, and it's quite striking for a lot of patients. The pharyngeal sidewall often will collapse in, and we can see maybe small tonsils that are actually quite dynamically obstructive when we do these hypotonic manoeuvres. What we're trying to replicate is that situation in sleep where they're low tone and the collapsing of the pharyngeal musculature, which brings those tonsils medially. See if that comes up. So this is our staging system. So the one on the right, the Mallampati score, we can see the position of the tongue and relationship to the palate, looking at the difficult airway. As we get down to 3 and 4, you can see here that our chances of success are very low. So 3, 4, it makes us really shy away from any significant surgical intervention, generally speaking. Our best chance of success is those patients with a great airway, so number 1 of the Mallampati score with large tonsils, grade 3, 4 tonsils with a low BMI. We know that we can get success in 80% of patients. But as we're getting higher in terms of the smaller tonsil size and worsening of the palate and tongue position, our chances of success become less than 50%. And those patients with a BMI greater than 40, we're talking about a success rate of 8%. So, already these patients are best suited to CPAP. We have to weigh up those surgical risks and anaesthetic risks for a patient with a BMI greater than 40. Now, I mentioned the sleep study, home versus lab-based. Obviously, it's the gold standard in adults, but not in kids, due to obvious reasons. Certainly, we will consider it in the patients we're suspicious of severe sleep apnea that may cause a problem post-operatively. So the large BMI, large tonsils, completely blocked nose, unreliable history from parents. These patients may need some high dependency unit monitoring, and sometimes, if they're young, say 18 months, 2 years of age, go up the road to the Queensland Children's. If there's, we often get patients present to emergency, the parents bring them in concerned about apneas, and they'll often be admitted for overnight oximetry to get us some idea of what might be going on through the night, but we don't use that for adults. Blood tests, yes, if you're looking at the sequelae, polycythemia, but not necessarily from a ENT surgeon's perspective. When we're talking treatment, and I'll obviously discuss some surgical approaches, but this is what we are telling all of our patients every time we see them. There's fairly significant conservative measures which have to be reminded to each patient, and obviously diet, weight loss, discussing their goal BMI with the assistance of dietitians is huge. If we can get their BMI down, we can improve the success of any surgical intervention. And often we'll get those patients, they have to get their weight down before we'll consider it. Obviously exercise and avoiding sedentary medications as best as we can, and alcohol. Obviously these are conservative nasal treatments, nasal steroid sprays with or without antihistamine depending on their allergic profile, but Dymista, Ryaltris, the new one, are common ones that we'll try in patients with those types of symptoms. Saline spray. So they're all gold standard for nasal obstruction, all level 1 evidence to support them for allergy, sinusitis and nasal breathing. Their evidence to improve sleep apnea is low, and we don't have that evidence, strong evidence to support it, but they're simple measures that patients may want to try to see if they can get some minor improvements. Nasal strips, obviously, with the collapsing nasal valve. So one of the sort of the more leaning towards some intervention, I suppose, is the mandibular advancement splints. We don't do them, we don't make them, but patients can try them. So they're like a double mouth guard, you can see up the top there, that tries to keep the mandible forward and prevents it from falling back. There's a little catch, I'm not sure. There's a little wedge that prevents the mandible from falling back, trying to maintain the tongue base forward to help prevent collapse. They're about $1,500, so not a huge amount of uptake, and largely help with snoring, but aren't going to have any major significant benefits on sleep apnea. But patients are often very motivated to try something like that if they can at all help prevent CPAP. Or at least, they may feel somewhat better, so they have subjective improvements, but their objective sleep study readings aren't significantly improved.
So private health funds will pay for that?
Help, some help, yeah. And otherwise, positional devices. So we always talk about the tennis ball sutured into the back of the t-shirt, and people are tapping into this kind of backpack idea with the bulky backpack to prevent people from sleeping on their back, which I think would be reasonably effective but somewhat uncomfortable itself, sitting in the one position all night. So CPAP itself, it is the gold standard, but it's less than 50% compliance rate. We have to be realistic about it. I can't see myself wanting something like that on all night with the noise of the machine, but it has an absolute role and absolute purpose, and is the most effective treatment that we have. There's no doubt about it. But you've got to wear it for at least 5 hours a night, 5 days a week, for that to be called compliance. There's different ways of getting the patient to try things. So the nasal masks or the full face mask, depending on their symptoms and often their nasal obstructive features. So a lot of patients with nasal obstruction won't tolerate those nasal masks. So what we'll often get is the patient coming in either pre-sleep study wanting some advice on which way to go, and otherwise their post-sleep study on CPAP wanting some help with their compliance. That's a fairly common situation for us. I'm just going to talk about surgery now and start with kids. Obviously, we're all fully aware of this option for children, and we know how effective it is. It's got strong evidence to support it. The tonsillectomy, the full tonsillectomy versus a coblation tonsillotomy. Is everybody aware of sort of au fait with tonsillotomy approaches these days? So, so just in the picture you can see the tubes at the top of the screen, and it's we use a coblation device, which is a non-heat sort of plasma device that changes the energy field to basically melt away the tonsil tissue, and we can use that to shave back the tonsils back to the border or the capsule to prevent entry into the larger vessels, nerves, improved pain scores, improved return to diet, and lower bleed rates. So we're talking a standard tonsillectomy is probably less than 5% bleed rate, and this is probably less than 1%. The regrowth rate is probably less than 10%. So it's favourable in the patients that don't get tonsillitis, that get a lot of sleep apnea, so children. And we don't do this really above age 8. It's favourable for the 18-month-old, the 2-year-old, 3-year-old. Beyond that, we're sort of often erring towards a tonsillectomy. And a lot of patients, a lot of parents are preferring a more definitive approach. Get the tonsils out, be done with it. There's a 2-week recovery period. I just want to do the 1 recovery period. But this is a good second option, and we do it commonly, but still more common to do the full tonsillectomy. Adenoidectomy, obviously, and otherwise treating the nose. And so the best evidence exists in children for 3-level surgery, so treating the turbinates, the tonsils and the adenoids. For the surgical options for the adults, we've got to have a specific correctable anatomical abnormality. You can see how thorough our examination is. We're not leaping in there and trying to treat all of these patients who are on CPAP. It's really very selective as to who we would consider operating on, largely because we have to lower the risks, anaesthetic risks, as well as being realistic for a lot of these patients, depending on their BMI and their sleep apnea scores. And what we would say is a success in surgery is not necessarily, hey, you're off your CPAP, see you later. It may just be a reduction in the pressures. It may be a reduction in their CPAP dependency, or a reduction from severe sleep apnea down to mild to moderate. And that has subjective improvements for the patient, but sometimes the objective improvements on the sleep study aren't always borne out. So we try and have a good relationship with our sleep respiratory physician. I know I do, send patients backwards and forwards. And we're largely looking at when, either if we've got a suspicion of severe, we'll often insist on a sleep study first because of the risks post-operatively. And otherwise, we're looking at patients, we might look at standard early approaches prior to then getting a sleep study, okay, rather than getting a sleep study first, doing surgery and then getting another sleep study. So often they've got to try something conservative, or they've been non-compliant on it, and we want patients with limited comorbidities. And certainly the nasal surgery is clearly one of our first, our common operations, but also our ideal first step. Like I said, it can help permit them to use their device, reduce the pressures, and also reduce the need for any further invasive surgery, so tongue-based or tonsil surgery. So we're talking the basics like septoplasty, septorhinoplasty if there's significant fractures or deviation of the bony pyramid. Turbinate reduction adenoids sinus surgery is unlikely to be a significant benefit to sleep apnea, but what we know is that it can improve the quality of their sleep and reduce snoring, and just may improve their CPAP tolerance. So those patients on the nasal CPAP will often have better tolerance of their CPAP after they've had their septum and turbinates done. The major ENT the major sleep surgery is in the pharynx, okay, and that's whether the tonsils need to be removed, or whether the palate's causing significant obstruction, or the tongue base. It's pretty uncommon for us to do significant tongue-based surgery because of the risks of bleeding, swelling, and the limited success, okay. One of the most common operations that we'll consider, and that apart from the tonsillectomy, will be the UPPP, the more favoured one being a modified UPPP, whereby and I'll show you some pictures, we're bringing the palate somewhat forward so it's not collapsing backwards. That combined with tongue-based surgery can have really good improvements in their respiratory disturbance index by up to 75%. But we're very carefully selective on those patients that we're going to operate on because often these patients are still requiring CPAP, okay, and we want to get that be realistic for our patients, making sure they've got realistic goals. But for the tongue, we're often doing this tongue-based channeling. So there's a fine wand, the coblation again, that goes into the tongue base very carefully, not cause hematomas, to try and lower the bulk of the tongue base to try and limit that obstructive effect. Robotic surgery, people have got more toys to use now to reduce the base of the tongue with better access. So when we're not doing cancer resections with robots, when the robot's available, when the urologist let us use it, the tongue base can be reduced with robotic resection, uncommonly done. Very painful. So this is just an example of that sort of pharyngeal surgery I just wanted to show you, where we're taking the tonsils out first, raising flaps from the back of the pharynx in the tonsil fossa. We're lifting up the posterior pillar. So when you look at the tonsils, the anterior pillar and posterior pillar, we're lifting up the posterior pillar, actually dividing it, okay, and reflecting it back and forward. Up and forwards, to hitch the palate more forward, okay, and then finishing off with a nice little uvulectomy, reduction of the uvula. And obviously there's risk of stenosis, there's risk of scarring or wound breakdown, there's risks of infection. The airways often looks like a bomb's gone off, and so they'll probably come to you for pain relief post-operatively, and you'll have a look and see all these sutures hanging out and bad breath. But this sort of final, I can't really, no pointer here, And final picture on the bottom right, that sort of L-shaped or reverse L-shaped scarring up onto the side. We've got to be careful not to hitch it too far forward for that risk of VPI, like I said, the food and air and water going up, and that's not a good outcome. But generally speaking, the risk of that is low. So less common operations. This is something that is rarely done. So geniohyoid advancement, you can imagine trying to bring the tongue base forward by bringing your chin forward. You know, we're not doing that. Midline glossectomy, so that's chopping out the middle section of the tongue, avoiding the nerves and vessels. Again, that's not commonly done. That's got to be a very, very carefully selected patient who's very aware of the risks of bleeding. There's been deaths in Sydney from this sort of surgery. One of the most effective in very selected patients is the maxillofacial approaches, osteotomies and advancements, often done in that teenage to young adult phase. I think rarely done in adults, but largely because it's, again, difficult to get the right patient for that sort of surgery. But they can have success rates of up to 80%, which can be actually just as good as CPAP in the right patient. Now, has anybody heard of hypoglossal nerve stimulators? This is all pretty wild. This is sort of coming in, and it has shown in the right patient to have some benefit. Stimulators on your cranial nerve, so opening your neck, finding your hypoglossal nerve, putting on a stimulator that's buried in your chest to stimulate your tongue to poke out as you're sleeping. So that's to bring, and timed in with your respiration. So as you breathe in, it brings your tongue forward. Now, clearly that's not commonly done and has to be well counselled patient on the risk to their hypoglossal nerve, but is something that people are trying to help patients to get when they just can't tolerate their CPAP.
Go back to weight loss.
Yeah. And obviously tracheostomy. Tracheostomy is 100% success rate for sleep apnea. We don't do that commonly. But in the severe, so a lot of the children, so, you know, not a lot of the children, but the syndromic kids, so there's Treacher Collins with a lot of these children with their upper airway obstruction have severe sleep apnea, and they do need tracheostomies regardless, and that's actually protective for them with their sleep apnea that's often present as well. So it's just my last slide. These are the sort of just the real sort of standard patients that we do see. So it is common, you know, every day, every session I'll see patients with this. The kids with intermittent snoring, apnea, stuffiness. Mum and dad have got videos showing me their child's head extended like a sword swallower, trying to get the air in as best as they can and rolling over, and constantly just walking around like a zombie in the morning because they haven't slept, doing 360s in the bed. And then the adults that are thin, healthy, snoring but low BMI, big tonsils but maybe not, and we're looking at trying to fix them through nasal operations and nasal approaches. Or the ones with CPAP that can't tolerate it, we're looking at ways to help improve those nasal pressures, that suffocating feeling, and but have to be mindful of, you know, of being realistic on what we can achieve without causing more harm. Yeah. Any questions, guys? Everyone's still awake.
Mm-hmm.
Hand out some Epworth sleepiness scales.
It's been less than an hour.
Yeah.
So how often would you do these surgeries? These palate surgeries?
Oh, it's not common. Probably one every 2 months or so. Yeah. In terms of, you know, like I say, we have to be quite selective. If I'm considering it, I'd probably prefer the patient to have a sleep study. A lot of the time, what we call facilitatory surgery, so that's the nasal surgery, so it's pre-phase. We try and get the nasal surgery done first to optimise them, just get the basics, and then we'll get a sleep study. And if there's ongoing issues, then we might have to look at their palate. Okay, and that's looking at that sort of multi-level approach. But the positioning of the palate is important to see whether that's actually going to be somebody who's going to benefit from that operation. Yeah. And they've often got small tonsils. It's just the position and their long palate falling backwards. And it's quite a effective operation. It seems dramatic to divide their posterior pillar and hitch it forward, but with sort of, I prefer to do it relatively conservatively rather than a significant radical bring forward of the palate. Then you can get some good results and good partner feedback too. Any other questions? No? Any ENT questions? No? What about steroid sprays and things? Everybody sort of familiar with those? Ryaltris and Dymista and...
It sort of a bit off the side. I remember hearing a little while ago about Botox intranasally for allergic rhinitis, but not injection, just stuff in the brain.
No, I'm not familiar. I haven't heard. No.
I just heard. I mean, I heard about it a while ago.
Yeah.
Wildly effective, but the early studies are always wildly effective. So
Yeah. No, I haven't heard of it. But just while you're in terms of other nasal treatments that I thought I should mention, menthol has been shown. We always think about those Vicks sniff and sticks and things like that. Always thought to be sort of really unlikely to help. They actually have been demonstrated to have a pharmaceutical, pharmacological mechanism of action whereby they sensitise thermoreceptors in the nose. So I'll often get patients onto those with nasal obstruction at night to have a sniff of a menthol inhaler because they sensitise the nasal receptors to trigger our feedback to the brain to say we can breathe. So it's the same receptors that are triggered with airflow and change in temperature with a breath in, and that gives you the sense of airflow. So we're trying to get patients off those decongestants.
Yeah.
So.
And is Ryaltris much better than everything else?
So Ryaltris and Dymista are about the same, but it's supposed to have a better taste profile. $45 to $60 a pack, but very effective for a lot of our allergy nasal patients. And for kids, I'll often get them onto a steroid spray, often because we've got to get them onto a surgical waiting list. So they're on a waiting list for 12 months or so. I'll get the parents just to do a 3-month trial of something like Avamis, which is from 2 years and up. Obviously the compliance rate is going to be low, but I've had patients who can get it in have benefit, but we don't want them on it long term, and the parents don't either. Even though the long-term side effects or long-term studies show it's safe, we sort of hazard, shy away from longer-term use anyway in kids. Yeah.
What's your favourite drops for otitis externa?
I just encourage a swab, making sure you've done a swab first.
Oh,
Yeah,
wow.
yeah, otitis externa.
Yeah.
Yeah, definitely swab. Yeah,
See heaps of it in January.
'Cause you're-
January, February,
yeah. Look, I think we just see so much fungal. We see so much grumbling, chronic fungal.
You
That-
do.
Yeah.
We probably don't.
Yeah. So yeah, I mean, I think it's reasonable to swab and try Sofradex. So, but it really depends on the patient and what you're seeing. So if you're seeing the fungal spores, cheesy white, then you'd be looking at something like Kenocomotic, as opposed to florid green, watery, water exposure. We're thinking Pseudomonas. And to be honest, we're seeing both. Like I've seen a few, with the floods, a lot of Pseudomonas and other fungal infections, and seeing a lot more chronic fungal too, where there's ingrained sort of fungal skin into the skin infection in the canal, needing oral antifungals, which I've never had to do before, but that's what's sort of coming out. But the swab does help you sort of guide your treatment if you can, and that's often the first thing we'll do. But don't be shy to use a topical antibiotic. We'll see a lot of patients on the oral, only started on oral antibiotics, oral Amoxil for an otitis externa, and of course they're going to come in. Yeah.
You go to Cyprite if you think it's greeny.
Yeah. I'll do.
Okay, or
So Suproxen HC is has the hydrocort. It's stronger. It'll sting a bit, but very effective with the very edematous canal. But it will cost $30 to $45. And so the patients aren't that keen on using it. Siloxane is our go-to for the grommet, the discharging grommet, because it's safe to use in the middle ear, penetrates through the grommet, and we'll often use that without an oral antibiotic, unless there's other systemic symptoms. And in that sense, I'll often use Augmentin as well as Siloxane. The Suproxen, I was going to say Suproxen will get through the grommet, but it'll burn a little bit on the other side in the middle ear. Yeah.
I still tell my patients to mop with
tissue spears. Yeah, absolutely. Yeah. No, that's always useful. Yeah, to get the most penetrance. Yeah.
Very satisfying.
Yeah. It's very uncommon. Challenging for us to get an ear toilet done in a kid as well.
Yeah.
They're already sore, pretty miserable, and we'll get referred in for ear toilets, but it's near impossible. It's like getting foreign bodies out, unless you've got full compliance. So, yeah.
If Kenecomox is not working, your second choice for fungal?
It's a challenge. Yeah, so Lococort and Viaform we can't get. Yeah, so compounding pharmacies can sometimes make it up for you. So I know Tugun Compounding Pharmacy will do it for us, which is clinical and betamethasone they put together into a drop. The challenge with fungal is that it will cause perforations if it's chronic, and then we don't want to use the antifungal getting into the middle ear. So then they're going to need ear toileting. So we'll do weekly ear toileting with judicious use of antifungal cream away from the perforation until that perforation settles down, and then get them onto a topical drop. So antifungal creams like Kenecomb cream, ointment, or Canesten, we'll often have to use, but we don't have really a second line topical fungal drop.
And the other one I often see is the dermatitis in the ear.
Yep.
And what are your recommendations?
Yeah, no, good question. Because that's often the cause of all the otitis externa. And so we often, get them back to get on top of that as well. So that dry, flaky skin, the history of psoriasis or dermatitis. So I'll use topical lotions, treat the infection first, and then look at topical steroid. So if it's outer, just a simple over-the-counter Betnovate. But my go-to at the moment is Zatamil, which is a mometazone lotion. So it comes in a dropper, like Aqua Ear, the sort of Aqua Ear shaped dropper, and it's liquid enough to penetrate down the canal. So I'll often get them to slam the ear for, say, 7 days, do an extended course, get on top of it, and then use it, say, monthly to help settle down that dermatitis. And that's been quite effective. I've got patients on Zatamil for, for a prolonged period. Yeah, they'll just use it PRN. Yeah. All right. Thanks, everybody, for being here. It's great.